I'd like to call this meeting to order. First off, I'd like to acknowledge that the TRHD, we connect with many First Nations communities across our vast regional district. And today we are located on Kamloops to Secwépemc territory, situated with the unceded ancestral lands of the Secwépemc Nation. The TRHD appreciates the partnerships that we have with the Kamloops to Secwépemc and respect the territory and land on which we gather today. Do we have any additions or deletions from the agenda today? No. Got an approval of the agenda? Moved by Councillor Newstater, second by Director Thorpe. All in favor? Thank you. Before we move any further, while we normally have a pretty standard group of directors around the table, we do have some temporary changes, permanent changes, and just some one-off changes. So just bear with me as we go through the list. And if I've missed any changes, please put your hand up and let me know. So we have in place of Director Stamer, we have Rob Kolaski from the Kersley, from Village of Barrier. We have Rob O'Toole, who is not here today, who is replacing Director Rain for the town of Sun Peaks. We have Director Carpuck, who is now here permanently in replace of Mayor Hamer Jackson, and we have him. We have Director Beppel from the City of Kamloops, who is temporary for today, who's here for Councillor Hall. And then online, we have Director Simpson and McNair. Do I have anybody else that I've missed with any changes? Sorry. Oh, sorry. Director Birch Jones, but she's usually online, but she's here in person. But it's nice to see your face, Director Birch Jones. And if we're doing that, then at the same time, we may as well say hello to Director McNary in the back corner at the staff table. So good morning. All right. Is that it? Okay. Perfect. All right. There we go. So if we can have an adoption of the minutes. Moved by Director Getz, second by Director J. Smith. Any errors, omissions? All in favor? Thank you, that's passed. We'll move into CAO report, verbal update from External Relations Advisor Corbin Kelly.
Thank you, Chair. Through to the board, I just wanted to provide a quick update on the Cancer Won't Wait campaign. As it's sort of now coming to an end. Our contract is set to end with Santis Health in the coming weeks, and so just wanting to share the success of the campaign. We've been able to keep the Kamloops Cancer Centre at the top of folks' minds and been very public and successful in the public in terms of advocating for the need of the Kamloops Cancer Centre. As we move forward and the political landscape in the province is starting to shift and we get ready for the provincial writs to be dropped and to go into a provincial election, in front of all of you, you would have received a stack of these cards. These are election toolkits is what we're calling them. And our hope is that you'll be able to take these back into your communities, take them back to your town halls. If you have community centers that you're able to lead these at, so that voters are able to pick these up and ensure that no matter what party a candidate is running for, that they're committed to keeping the Kamloops Cancer Centre at the top of their priority list, that they're committed to funding it no matter who forms government. And that it remains a priority for all political parties. If you would like more, trust me, my office is full of these. So please let me know. I'd like to get rid of them. Because it does no use sitting with me. It needs to be out with voters. And so the same thing would go if you're able to connect with candidates, or if you're going to all candidates forums in your respective communities. Please feel free to take these and hand them out to voters to ensure that they're up to date. As I said, our contract is coming to an end with Santis Health. So we'll be wrapping up with the consultants. They'll be able to share some statistics with us in terms of the number of engagements that we've had. They did have a booth at the Kamloops Ribfest, which I know a number of you participated in, so thank you for that. And I know that was a huge success in terms of being able to engage with the community. So I'm not sure if there's any questions. I've got bags of pins that say cancer won't wait on them. I've got bumper stickers. So let me know if you would like any additional materials, and I would be happy to share it. But thank you, Chair.
Thank you for that report. We have Director Newstater.
Thanks through the chair. Hoping we can get a digital version as well sent to the board.
Yes, I'll make sure that we send out a digital copy.
Thank you.
Thank you. Seeing nobody in the room and nobody else online. Thank you very much. We will move to 5.2 and we have Royal Inland Hospital update.
Thank you very much. My name is Gerry Desilets. I'm the Executive Director at Royal Inland Hospital. I also have the surgical network under my portfolio, and I'll be updating on RH capital plan. Thank you. So I'd also like to give an acknowledgement to the land that we're currently on, the unceded territory, the Kamloops, where RH currently stands, and very thankful to be an uninvited guest on these lands and enjoy everything it has to offer. So a bit agenda for my presentation. There'll be another presentation for my rural components and community partners. So the Patient Care Tower Phase 2 project update, Kamloops Cancer Center update, the Barrier and Clearwater X-ray update, and answer any questions you may have. So the Phil and Jenny Glardy Tower Phase 2 update. So renovations continue in all major departments. The project is scheduled to complete fall of 2026. Milestones completed since the last update in June are the afternoon auxiliary post-anesthetic recovery room, the pediatrics unit, and the ambulance stretcher hoarding bays. So there's a couple of pictures of the new afternoon auxiliary post-anesthetic recovery room opened for patients on July 3rd. It's a new PR unit named after the auxiliary for its contribution. The PR unit is located on level 4 of the main building for seamless access from the operating rooms to the Phil and Jenny Glardy Tower. The new features include a new design that meets modern clinical and infection prevention and control standards, an optimized layout for efficiency and flow. They've increased capacity for patient care from 16 recovery bays up to 26. And there's also 2 single patient recovery rooms for patients requiring higher level of infection control and specialized care. And the latest cardiac monitoring technology. This is doubling the work and support areas for care team and dedicated shared workspaces for anesthesiologists and surgeons. Next are some beautiful pictures of our new pediatric unit. So this also opened in July, on July 23rd. It's filled with elements to spark joy with bright and colorful spaces and interactive wall-mounted toys and waiting areas. The renovated spaces come with 9 single inpatient rooms, including 1 negative pressure isolation room to contain airborne illnesses. Each individual patient room comes with a unique design and color scheme, its own private bathroom and shower, and amenities for adult caregivers. Example, a sleeper chair set for sleeping and a nook in the rooms. There's 2 clinical rooms for outpatient care as well as 1 for inpatient procedures. The idea of this is we don't want to provide procedures in patient rooms because then they equate that with painful procedures and things. So we separate that out, which provides better care to our smallest patients. There's dedicated observational alcoves and specialized spaces for interventional procedure rooms and milk preparation room, a place outside patient rooms for added privacy and comfort. This is a picture of the ambulance stretcher holding bays. This is a new area. This allows the BC ambulance team to transition from the ambulances to the hospital while they're waiting for rooms actually in the emergency room space. It has dedicated head walls, ceiling lift equipment to help lift patients, curtains to enhance patients' privacy. They're located in a convenience location between the ambulance garage and the ED. It now only facilitates faster transfers and coordination, but also frees up existing space in the emergency department. For any who've been in there, we used to keep a lot of these patients actually in a hallway and stretchers until rooms could become available. Now they actually have dedicated space. So it's a very much added need. So I think the big one that's coming up is our new tech emergency department. So the first large phase will be coming open. I think we'll see the biggest difference. So this is the entrance triage, patient streaming and rapid access area where the main entrance is on the roundabout. That will be completed end of September for the staff to get things organized and filled up. And then hopefully for staff at the end of October will be, for patients and public. You can see on there the remaining phases. So the next phase will start as soon as that phase starts is the new mental health and substance use care area. And a portion of the new acute treatment zone that should be completed in summer 2025. The remainder of the new acute treatment zone, where we hold many inpatients provide other care in spring 2026. And the last section would be completed as the new trauma and resuscitation zone to be completed in fall 2026. And that would close off the phase 2 renovations within this. Also scheduled to end at the end of 2024 is a daycare surgery elevator lobby, just to refresh that area between PAR and daycare services. So a quick update on the Kamloops Cancer Center. So there was project costing updated completed in July 2024. The result is no adjustments to the estimated budget of 359 million. The next project update will be in spring, will coincide with the conclusion of the tendering process. So just to follow up on, I know there's been questions in the past around the procurement models for these two projects. For the design and build fixed price will be for the new facility. So that'd be the Kamloops Cancer Center, and construction manager contract for the RH upgrades. And 2 teams to participate in the RFP stage, which we're currently in, is Ellis Dawn Corporation, who's currently doing the build with the Phil and Jenny Dougherty Tower in phase 2, and PCL Construction West Coast Inc. Projected timelines would be May 2025 to have the design build team chosen. Summer 2025, construction begins. In December 2028, the new facility would be completed. And in summer 2029, the RH upgrades would be completed. So no, there was questions before around some of the rationale of creating for chemotherapy located in the renovated RH space and not in the new building. So number one, the new building space has constraints. The building footprint is already maximized based on land available, and the planned height already requires bylaw variance. Number two, the pharmacy needs to be close to for the chemotherapy, and the RH planned chemotherapy location is next to the existing pharmacy, which would also be renovated within this work. And moving chemotherapy to the new building would also require construction of a second pharmacy, as existing RH pharmacy would be too far away to transfer the medications. Dan, do you want to talk about the X-ray? You just want me to keep going? Keep going, all right. So this also came up at the last meeting, just around barrier and Clearwater X-ray needs. So new X-ray equipment has been ordered for both locations. Delivery equipment will be in 2025 with suite upgrades and installations to follow. The funding request for Clearwater will be included in the 25-26 funding request. Expected delivery dates and construction schedule will be advised at the December TRHD board meeting. Both locations require replacement of the X-ray equipment and upgrades to the suites. Both locations are experiencing some limitations on the types of exams that can be performed within the main X-ray systems and are augmenting with portable X-ray equipment to manage that. The barrier project funding was included in our current year 24-25 funding request, and we have ordered new X-ray equipment for both locations, and equipment has a long lead time to be delivered. And that is my update. Any questions?
Thank you. We'll start with Director Bass.
Thank you. My former reporter DNA is taking over here, so I apologize. Given the less than favorable media that the health authority is getting and how it impacts down on RIH, I'm just wondering, given the size of its communications department, why when I was a reporter covering health, we would get press releases that would say, new pediatric center, yay us, new ambulance bay, yay us. We don't get that anymore. And I'm just wondering why we're not celebrating the little things and letting all of the really big problems just control the media.
Yeah, there will be some announcements tomorrow by the ministry, and then we will definitely ramp up our celebration of these spaces.
Supplemental. Cynical reporter here. Is the announcement simply because there's an election coming? I'm not a Dick's fan, and I think everybody in this room knows that. So I'm just kind of curious.
Yeah, I don't
Why?
think that question needs to be answered, but your point's taken as general commentary. Thank
It
you.
was my rhetoric.
Director Bass. No, thank you. Director Blackwell.
Yes, thank you. I have two quick questions. The first one is on the stretcher holding area. Once the patient is transferred into the hospital bed, does that allow the paramedics or the ambulance team to leave, or do they have to remain with the patient?
Yeah, so the ambulance bay, the holding area would be for the ambulance crew to stay with the patient
Okay.
until they transfer to the beds.
Okay.
We have made huge advancements in the turnaround time of ambulance crews and actually our CMP in
Yeah.
the last few years. So talking with those partners, they're quite happy with that process. This just gives a better care area because currently they are literally in a hallway with a wheeled oxygen tank. So they're quite happy with the new space, and I think it gives better care to the clients. And I think it will, as the new unit opens up, we'll continue to expedite the time of them getting back on the road.
Yeah, no, thank you for the clarification that that also working on the turnaround time to get crews back out into the field. That's fantastic. Looks like a great space, and I'm quite sure it'll make everything run smoother. Specific to the Clearwater X-ray, fantastic that that's ordered. Any more specifics on the timeline? Just 2025 is sort of a thing. I know the local hospital auxiliary has raised I believe $310,000 to this point out of the 350 needed. And you also mentioned renovations happening after it arrives, or is that equipment arrives in 2025, then we figure out how to make it work into the room? Is that how this is working?
I might have to ask one of my colleagues on that one.
Okay. Thanks.
Yeah, Karen.
But just trying to figure out what we need to plan for at our end. Thank you.
Director Blackwell, it's an excellent question. And so barrier was planned ahead of Clearwater, and then Clearwater suddenly became a need. So ordering in bulk did provide us with some cost savings on that X-ray equipment. But like anything post-pandemic, what you order and the turnaround time on delivery of that. So the estimated time of delivery is December. The installation will include some upgrades to the space, and so those are already being prepped and readied for that arrival of equipment. So I think it's safe to say in early 2025, the new X-ray will be up and running. Given that we don't run into anything and any surprises, and those of you who've renovated your own homes know that sometimes happens. So.
Thank you. Thank you for that excellent answer.
Yeah.
Thank you.
Thanks.
Thank you. Director Bebel.
Thank you. Thanks for the report. My question is not in the report, but unregulated drug toxicity is now the leading cause of death from 10 till 59 years of old. And it's the leading cause of death from 10 till 18. And the number of people dying of toxic drugs is more than homicides, suicides, accidents, and natural disease combined in BC. So what is Interior Health planning or doing to expand services to address this astounding death rate?
Yeah, I think this is something that's home for everyone, and it's a worldwide issue in Interior Health. There is a lot of resources going into look at harm reduction, look at different services, and there's a lot of work happening with a dedicated team to that. So for specifics, I have to reach out to the team and get some information back to you, but definitely happy to bring that back as a response next time.
Thank you for that answer. And for Director Beppel, just so you're aware, Gerry is the Executive Director of Royal Inland Hospital, and that's his role. And we're here more to talk about capital and the investments that the TRHD have made, not so much operational and IH-wide. Those are more held for other meetings. So thank you for that. Thanks for that question. If you could just, I have a question and a comment. If we go back to the slide regarding the Cancer Center and the height difference, I believe there was a slide on there. It was your point number one. We can go further.
I think the
Yeah, one more. Getting closer. There we go. The new building constraints, just for point of clarification, the bylaw variance piece, that's obviously held by the city of Kamloops, and we've been very supportive of any changes that need to be made, not but just by Royal Inland Hospital, but by Interior Health in general. And we would gladly be at the table if it helped make a better cancer center in Kamloops. So I just want to clarify that. And just the question regarding the pharmacy. And I mean, when we talked about having to renovate and move things or have two different ones, my understanding is that even just the pharmacist specifically needs to be a cancer pharmacist specialty. And that's its own profession. And are they going to be there operating? And it's not just put on the side of just the general pharmacists in Royal Inland Hospital, and that's their focus. And I believe I brought up at the last meeting was regarding the drug navigators. And that's a very big piece of component and patients going through cancer treatment. So if you comment on that, please. Thank you.
Yeah, we do definitely have specific pharmacists because we are currently providing the chemotherapy in the hospital. So we do have a group that provides that. We used to actually provide the drug mixing up on the 8th floor where the cancer clinic currently is. We have now moved them back downstairs, and this being on both on the 1st floor would allow for that piece. Part of any of the expansion, we are looking at all staff and what we need, including drug navigators and pharmacy specialists in this with medication, as also increasing our medical oncologists. So that is all part of the plan as we're moving forward and making sure we have the appropriate resources to provide the care.
Thank you. Any directors? Director Thorpe.
So, thank you. So given what Chair O'Reilly just said about the variance for the new building potentially not being an issue, and what you're saying about the specialists required, the special type of pharmacy and pharmacists required. One of the questions that we had at that June meeting, Director Bass and I asked about the cost differential between bringing everything into the one building to make it more compassionate for the patients, as opposed to having it separate like that. Do you have those numbers for us today?
No.
Okay, because that was what we asked for in June, I believe. And if you could bring those back to us, it would be greatly appreciated. Thank you.
Thank you for that for Director Thorpe. Do we have any directors online that have a question? I can't see the grid of people, but staff could bring that. Oh, there we go. Thank you. Director Demare.
Thank you. Could you please give us an update on the Lillooet X-ray machine? I was there yesterday and I for X-rays, and I had to go into the old X-ray room to have it done. So if you could give us an update on that, I'd appreciate it.
Yes, thank you for your question. I'm happy to report the Lillooet X-ray installation is well in progress and on target to complete on time. I don't have the exact completion date, as X-ray services are under a different executive director, but I was at the site recently to observe the construction. That is a site that, as we started to cut holes in walls, we realized we had some other deficiencies to correct. So it is still moving ahead as scheduled, and barring any more hiccups as we cut into these older buildings, should be done on time.
Thank you.
Thank you. Director Laird.
Thank you, Mr. Chair. Similar question to the X-ray machines. Is it supposed to be in Merritt? Are they there yet? Or like I was talking to some of the staff and they were getting a little frustrated at timelines.
Oh, yeah, I bet. I was not aware Merritt was up for a replacement, so I'm going to have to commit to circling back on that question.
It's been on, I think, it's been over a year now, and it still hasn't been put in place.
Absolutely commit to getting that question answered for you. I just don't have that information in the moment.
Thank you.
And if we can maybe have that emailed rather than waiting for our next board meeting, because it isn't until December at this point, would be appreciated. Any further questions from any directors? Nothing further. Thank you for your presentation. Thank you for coming in today. We will move on to item 6, which is correspondence. All of you should have received a letter in your blue folder, and I believe that's going to be discussed here shortly. And if you don't have it physically, I believe the directors online had it emailed to them, and if staff can confirm that with just a nod would be great. Yeah, and I'm getting a thumbs up, so that's good. We all have that correspondence.
me, Chair.
Oh, sorry.
I apologize. Interior Health are not yet done with their presentations. They've got a few more things to say.
Sorry, yeah, that was the RH, and then now there's a community and long-term care.
Sorry, I don't have
was
that on
the-
my agenda. So if Interior Health wants to continue on with their presentation. Thank you.
All right, thank you, everyone. So for anybody that doesn't know me, I'm Kathy Doull. I'm the Executive Director for Clinical Operations for Kamloops community, which also includes the Thompson areas of Chase, Barrier, and Logan Lake. I will be co-presenting with Karen Cooper, who you've already met a couple times today, who has Thompson Caribou Rural. Let's go to the next slide. How do we switch slides? Oh. You switch, thank you. There we go. Just going to be talking about long-term care today as requested from a previous meeting. And we're going to talk about inventory, forecasting, criteria, allocation, and access. So first of all, just want to talk a little bit about what long-term care is. Long-term care is not just, everybody that's old doesn't go into long-term care. It really is for adults who can no longer care for themselves in their homes and require 24/7 nursing care. There has to be significant risk if they remain in their home, and they have to be investigated and treated for any medical causes of disability. What we don't want is somebody who has confusion that ends up in long-term care, and then once that resolves, they could be remaining at home. And when they're in long-term care, our goal is really to keep residents as comfortable as possible and receive supportive care. We always adhere to the principle that home is best, and we really only consider long-term care when we've exhausted all of the community resources to keep somebody at home. We're doing a lot of work in the communities to enhance community services to support individuals to age at home, such as increasing home health and home supports, adult daycare, respite care, and other things. One of the things that our primary care network plan just got approved, and that will provide a significant number of primary care providers, and that's an interdisciplinary team which will help keep individuals at home. Because of all that, we're actually seeing long-term care length of stay decreasing. So just to talk a little bit about our current inventory, across Interior Health, there's 5,700 long-term care beds. And then in IH West and Kamloops area, there's 948. The reason the total number is important is because many people choose to move outside of their home community to be closer to family. And so people have a choice of where they would like to go across the health authority and across the province. Just going to talk a little bit about some of the new additions. So we have seen there's 405 new long-term care beds that will open in this current calendar year across Kamloops, Vernon, Nelson, and the Central Okanagan. So we have seen some open in Vernon. We have some coming in Kamloops soon. We have 140 beds coming in Kelowna. There's also many other that are in the planning phase between Interior Health and the ministry. The current and planned new long-term care homes are really part of a longer-term strategy focused on where there's the largest demands for long-term care. We're always looking at the wait times for admissions, the referral pathways, and the population projections, as well as the specific needs of populations, including complex medical needs and long-term care that's more geared towards young adults. Just going to talk about forecasting and turn this over to Karen.
Thanks, Kathy. So there were some questions at the last meeting around how do we forecast and plan out for long-term care? And Kathy referenced population being the very first thing you look at. In fact, in the past history, it was the only thing that was looked at. The number of folks living in your area that are over the age of 75 And that is still predominantly the population we are serving in long-term care. Councillor Beppel made the point around our overdose and toxic drug crisis. And so we are seeing an increase in young adults with acquired brain injury as a result of that crisis that have the total care needs that long-term care provides. And so that's a population we now need to plan for. Another population on the rise is our bariatric population and the specialty equipment and services to provide total care safely to that population. So it's no longer just a straight formula of the percentage of people over 75. You need to factor all of these things in our population. Our population is becoming more multicultural, and the ways that folks want to age in place is something we're really excited about supporting. And so Kathy mentioned the comprehensive suite of seniors care services that go with home is best as a philosophy. So very, very happy that we have a seniors health and wellness center in Kamloops that serves the surrounding areas as well. What we know supports people to age in place and the home is best philosophy the most is to have that informal caregiver support network, support group that augments all those services you see that we provide and that we partner in the care for our clients to remain in the home. Staffing. When we think about where we wanted to put new builds, obviously we want that closer to home principle to be factored into our long-term care sites. But what we know is there are economies of scale of building larger sites. And we also know that building closer to urban centers helps us with staffing the facilities once they're built. In fact, we've had recent experience with rural builds where we weren't able to open all the beds due to the challenges in finding staff. So given that and Kathy's comments already around how we are seeing a shift in our population, welcoming care into their home, participating in some of these other services that are embedded in our community, and really moving to that philosophy of enabling people to remain in their homes as long as possible is how we're going to be where we need to be. Given that though, with our projected population growth, we know in this Thompson Health District, we're going to need 200 to 300 new beds before 2030, and we are actively planning for those. Next slide, please. So I'll wrap up the presentation on long-term care. Oh, yeah, I guess I can advance it myself. By talking about the criteria to be qualified for long-term care, I think probably all of you field questions about what it's like to be on our long-term care wait list and what does that mean? And then when a vacant bed comes up, how do folks actually access it? So I'll walk you through those things this morning. So as Kathy mentioned, in order to qualify for long-term care, you have to have high care needs that require that 24/7 care provision. We need to look at that suite of services that was on the previous slide at exhausting everything possible to help folks to remain at home. But eventually the assessment will deem that the care needs are at a long-term care level and clients are then approved and put on a wait list. In an ideal world, that occurs the majority of the time from community. And for this area, about 60% of folks going into long-term care do actually go in from their home. The other 40% from an acute care location. And therefore the last bullet point really is that going to long-term care from an acute care location is really considered an exception. And that's when discharging someone from hospital to their current home situation would result in safety risk concerns, and it doesn't make it tenable. So once you qualify based on the criteria on the previous slide, beds are allocated when they come up using provincial guidelines. And so the majority of people that go into long-term care qualify under the third bullet point there. When you go on the wait list, it is the order you were put on that wait list. So it is a chronological wait list. And so everyone is considered at a moderate risk level. However, as we know, putting someone on a chronological wait list doesn't mean that their care needs change at the exact same time as the next person on the list. And so obviously we need a process where somebody's risk level bumps them up the list into that bed. And we use the term intolerable risk. where it really is no longer possible to maintain care for that person in the home. The other thing that was really important and was part of the seniors advocate review was keeping couples together. So if one spouse is already in long-term care and the spouse that's at home qualifies for long-term care, we actually prioritize reunification of that couple. And I really have seen that principle be just really powerful. So I'm glad it's a principle that we have in place. As I said, though, the majority of folks going into long-term care, it is in chronological order. It may not feel like that. You may field a call from your constituents saying, I've been waiting forever. So that's why I included this slide. When someone qualifies for long-term care, they are asked to choose a preferred care home. Typically in our rural sites, of course, that's in their home community. In Kamloops with 7 and almost 8 long-term care sites, that preferred care could include many sites. You're not limited to just one. However, at the time you're qualified for long-term care, you're also asked to pick an interim care home, somewhere you would go until your preferred care home has a vacancy for you. So this interim care home sometimes does require that folks move out of their neighborhood or out of their community until they can get their preferred care home. So the wait list is managed by an access coordinator, and it uses a very sophisticated software system that when a bed becomes vacant in a site, they look at whether it's going to be offered as an interim or a preferred care home to the next person on the wait list. And so by doing that, we ensure there's fairness in the process and equitable access to all folks going into long-term care. So I think that is the end of the presentation on long-term care, and I'm happy to take any questions that arise.
Director Sal.
Thank you, Chair. Just looking at the presentation with over 300 beds, coming online in the near future, I'm just wondering if it would exacerbate like current staff nursing shortages. Like we already have facilities that are, closing because of the lack of nurses. So if that's, part of the HR strategy.
Yeah, absolutely. So as you're planning for your capital builds, what I'm hearing you say is, what is the health human resource planning? Are we increasing the bums in the seats in both our nursing and care aid programs? And the answer to that is yes. Are we doing it at a pace that will match? That is the $64,000 question for sure, and the crystal ball question. I was chatting to Lee prior to the meeting around, this is a workforce that works differently than past generations. They want flexible hours and flexible locations and work-life balance. And so are we training enough? That is why we are moving towards the larger bedded sites in larger centers. Because the struggle in rural is very genuine and very real, and the struggle in urban is somewhat less. The other thing we have is the healthcare access program, where we actually now fund people to go into the health professions, pay for their schooling, provide them employment after graduation. So it really is all of those strategies to entice folks into healthcare professions. It's a great question.
Thank you for that. And I'll just list off the speaker list just because there's quite a few on here and so everybody knows what order. Our Director Houghton, O'Reilly, Sarai, Beppel, Roden. Director Houghton.
I'll make it quick. Thank you for your presentation. Just to understand how the system works. My daughter works at Count Seniors Village, and her job is to, I believe, she doesn't share too much with me, but keeps everything close to the heart, but is to fill the beds that I think you come in on a voluntary basis if you not from Interior Health. So is a place like that got like 2 sections to it where somebody puts their mom and dad in there and probably looks after the funding, and then is there a section of a place like that where Interior Health puts a different clientele in? Or I just don't know how they all work.
No, it's a great question. So we have a combination in Kamloops in our long-term care beds of purely IH owned and operated sites like Overlander and Ponderosa. The site where your daughter worked is a contracted partner site. So we have subsidized beds where the beds are paid for by Interior Health, but they also have private pay long-term care beds at that site for folks who choose to have their loved ones go in rather than stay on our wait list. The majority of people who opt for private long-term care are also concurrently sitting on one of our wait lists for an Interior Health funded bed. And that's what some families are able to do. Yeah.
Thank you. I'm next on the speakers list. Thank you for the presentation. And this is something the board asked for a while ago, but it really helps us understand better the long-term care bed situation in Kamloops. But I'm wondering if you have answers or can get them to us specifically regarding ratios. So we talk about, I mean, we're the Thompson Regional Hospital District. But obviously, you're talking IH West, which goes outside of our boundaries. And so I'm wondering what the ratios are like for IH West compared to the other areas for Interior Health. And when we look at 100 Mile and Williams Lake, if those areas aren't serviced properly, that puts significant pressure on other areas, specifically the Kamloops areas that people are looking for beds. And really, it comes down to what that ratio is for IH West. And the rest of the Okanagan, frankly, and further out. So where we stand on actual amount of beds for the population, as you spoke, but also the ratio where we're at with wait lists compared to population compared to other areas of IH.
Yeah, that's an excellent question, and I can reassure you that that data does exist. What I do know and can answer confidently in this moment is that we have a mix. So yes, there is a ratio of optimal number of long-term care beds per population, and some of our communities are underbedded. Some of our communities are actually overbedded. You referenced Williams Lake. And so it moves though as your population projects because of the length of time for a new build. In one moment, you might be in that sweet spot or slightly underbedded, then a new site opens and technically by that ratio, you're overbedded. But absolutely, we have that data for every community.
Thank you. And just from our side, we're the board for TRHD. So we're not looking at all of Interior Health. We're looking for the pressures that are put on our residents in our regional hospital district. So thank you for that. Director Sarai.
Thank you, Chair. Just a question when you mentioned the wait list. So in our city here, Interior Health funded long-term care homes haven't been increased as far as I'm concerned in a long time. More private business owners have opened up care homes, and they usually target the people that can pay the highest fee for care. So I'm wondering, when are these wait lists going to be decreasing, and what investment have you done in creating new beds in our region here?
Yeah, so thank you for the question. I think on the slide, you'll see there are some new beds coming online in Kamloops relatively quickly. And those announcements should be coming soon about the date of opening. And so when we talk about private beds, there are contracted sites, as Karen said, that have both IH funded beds and private beds. There's also other private options that people make use of, including independent living and assisted living, that often people who aren't yet ready for long-term care, but still want to be in that type of environment choose to go in. So we are really looking at how do we increase the access to those sites, and we are adding new beds ongoing. I don't have the actual wait list time. That's a great question, and I'm happy to bring that back and talk about what our wait lists are.
Thank you. Director Babel. Director Babel.
Thanks so much for coming in. So Ponderosa and Pine Grove are in the center of Kamloops. They were built close to 60 years ago. All of the other long-term care facilities are at the periphery. So for instance, Hamlet's is 14 kilometers away from the center. I like that you said keeping couples together. My experience is the people who visit extended care the most are the spouses of the people that are there. And by putting the extended care facilities at the very edges of the city, and the most recent one is into Kamloops, it's more and more difficult for spouses to visit. And I say that because I know from experience that many of those spouses have to take public transit to visit. And I know people in my own circle who do that sometimes every single day. So I appreciate that. It looks like Kamloops maybe will get 200 more beds. That's fantastic. But if every time we build a long-term care facility, it's further and further away from the center, and it has less and less access for the people who are going to be visiting the most, who, if the average age in long-term care is 85 years or older, then that's the age of the spouse. And to expect them to always be able to drive, I don't think is a fair expectation. I would ask that you really look at who is coming to visit the people in the long-term care facilities and how are they going to get there? Because I don't think that that's actually being considered as much as it should be when I look at the most recent facility that you built.
Thank you, Councillor Bethel. That's a very fair comment. I think there's a lot of different factors that go in to determine where a facility will be built, including where there's available land and space to do it. There's also, I think that is where a community comes and wraps around an individual to help support them to access their loved one, and the transportation it can be a challenge. Things like Handy Dart and other things are available to help people get there. But I agree with you. I think that's something that we always need to consider.
Thank you. Director Roden.
Thank you very much. I'm from Ashcroft. Can certainly see the rationale behind putting these facilities in large centers. In Ashcroft, 37% of our population is 65 or older. About 16% of that is 75% or older. Many of these people also have spouses who would like to visit them, and it's a lot longer to go from Ashcroft to Kamloops than it is to go from one side of Kamloops to the other. I would argue that we do need more of these facilities in smaller communities so that the people who help to build these smaller communities can age in place, and so that they are not isolated by having to go to places like Kamloops where friends, family can no longer visit them, and they are completely severed from the communities, which in so many ways they are such a huge part of, because these are the people who have volunteered for decades and who have worked there and raised kids there and taught in our schools. Along those same lines, I'm not presuming to teach grandma how to suck eggs here when it comes to recruiting, but I think maybe hand selling in every single secondary school in BC, particularly in the rural areas, going physically into secondary schools and talking to graduating or soon to be graduating students, particularly in rural areas, because it is going to be much easier to convince people who grew up in Clearwater, in Lillooet, in Ashcroft, in Barrier, in Chase, to come back to those communities and work in healthcare there than to convince someone who grew up in White Rock, in Surrey, in Kelowna, that they want to go to these small towns. I don't know what you're doing for recruiting in high schools. I would hope you're really focusing on our rural communities and going in, like I said, and hand selling. They're not huge graduating classes. It's not going to take a lot of time to meet every single student, and try and convince our rural students that that these are good, viable careers, and that if they choose to remain in their home communities, which many want to, they will have a career and a future there, because that is just a win-win-win for everyone.
Hear, hear. We'll bring you with us, Mayor Roden, because that's exactly the message. We need to make healthcare sexy again as a career. And we are always employing. It's pretty much recession-proof employment. So are we going into the schools? Yes. And one of the programs I'm really proud of is I talked about the healthcare access program, but the partnership with the school district to offer dual credit. So you get credit for high school, and you can begin your path towards a healthcare career while you're still in the high school setting. The other thing we're initiating at several sites and really based off what we're seeing in the larger centers that we need to replicate in rural is a really robust volunteer program. We won't call it candy striper because that's a very outdated term, but bringing youth into our facilities to demystify healthcare, to see that it may be an avenue or a pathway for them. And then, as I said, the extensive sponsorship that now exists to support people to go into the healthcare profession. So I couldn't agree with you more. And those are some of the things that we're doing. And I look forward to thinking about what that could look like for Ashcroft.
Thank you. Director McNary, did you have your hand up? Sorry.
Yes, I did. It was concerning the home care program. I have a personal experience with it. I got a phone call this morning. My dad's 96 years old. I got a phone call at 7 something this morning saying they're not going to be there. And that happens without any word of a lie, 65 to 70% of the time. I live in Lillooet, and and they're talking about all this home care stuff. They're not taking care of the basics right from the beginning. And I don't know what their problem is, but there is a problem there, and it needs to be dealt with and looked at personally, because I'm dealing with that all the time. It's ridiculous. I can't go nowhere because he can't remember to take his pills, and they're talking about danger and whatnot. And that's what it is. And I'm not sure. They say they're hiring and everything else, but it's not working. Whether they're going somewhere else to go to work or whatnot, but it's not being fair to the public that they say they're doing this and they're actually not doing it. They're doing it about 40%. And that's not acceptable, I don't think. You got to get 70% in college to pass. This is 40% for the province, and it's not right. Thank you.
I appreciate those comments and the struggles you're having in Lillooet. And I do know that our home support workers, which you're referencing, we're sitting at about a 50% vacancy in Lillooet. So it does make it challenging to deliver on the needs of that community. And so, as I articulated earlier, we absolutely rely on families and informal caregivers to partner with us. And you're articulating that burden has shifted mostly to family in your situation. I can say that in addition to the healthcare access program in Lillooet, we do also have an Indigenous specific healthcare access program in our rural sites with large Indigenous populations. And the hope is the uptake on that. Plus, our healthcare access increases the amount of care aides in our rural sites because our current staffing levels are not, based on your example, meeting the needs for your family.
Supplemental.
The only other thing I can say about that is how do we get heads up? Like, I come over to this meeting this morning, I get a phone call at 7:30 that they're not going to be able to do anything there. How do I deal with that personally when I'm already on my way over here?
Absolutely. So advance notice and last minute cancellations are really challenging and really tricky and really difficult. And I'm happy to work with you offline in your specific case to see what we can do to improve that.
Okay,
Thank you for
thank
that.
you.
And we have 2 more speakers. And so we'll go Director Grenier and Director Getz to close. Director Grenier.
My question's been asked. Thank you.
Thank you, Director Getz.
Karen, could you call, we're talking about Chair Roden, Ordinary Person Roden. Director Roden mentioned the fact about going into schools and stuff like that. Could one of the things that I'm concerned about, and I have talked with the minister about, is retention and return on investment and time served for, let's be honest, some of the doctors and nurses get interest-free loans to go through their programs. And we would expect as Canadian taxpayers to get some of that back before they're off to Ireland or off to America or wherever they go to. And I speak on personal experience because my niece was in 3rd year and got headhunted to Visalia, California. Is there anything in the works where we will have to be like Depot with the RCMP, where there is northern service or small community service before they can transfer out or transfer into a bigger community? We're looking for this, suggested this several times, and I'm just wondering if that's been in your horizon or on the books or anything like that for return to service?
That concept has not come up specifically in healthcare. It's an interesting one. What we do have for those programs that I've mentioned is that 2-year return of service, and that includes our new signing bonuses for rural and remote, which if folks aren't aware, those are substantial. It's $20,000 a year. Sorry, $20,000 signing bonus and then an $8,000 a year retention bonus based on a full-time equivalent. The signing bonus comes with a 2-year return of service, and then the 8,000 is a retention bonus ongoing. So we're hoping that by incentivizing, that's a strong way, and we're seeing it already in our vacancy reduction in rural and remote since those incentives were introduced in April 1st. I'm intrigued by your proposed concept and I'm willing to have further discussion, but at this point, I have not heard it be raised as one of our strategies for rural and remote recruitment. So I appreciate you bringing it forward.
Excellent. Thank you very much. And assuming I have the right agenda, we should be good for interior health at this point. No other presentations. All right. Thank you very much. Thank you for coming in today. Okay, we have already done item 6, which is the correspondence that you received in your folders at your desk. And the people online should have received it electronically. And we will go to new business and Director Birch Jones.
Okay, thank you. And thank you for allowing me to put this on the agenda. I believe you all have the letter in front of you, written by our community, our new Chief Executive Officer with Lillooet, along with all 6 of our Northern Statlium chiefs. Substantial statement. I moved to Lillooet like in the late 80s to work in the little hospital. At that time, 32 beds. We did maternity, peds, long-term care, emergency, of course, surgery. It was a functioning, happening little hospital. We had a board. It worked really well. And just full disclosure, my husband worked as a doctor, a rural doctor, including in the emergency, for over 30 years. And most of those years, he was the chief of staff. He has since given up his license, so I'm not in a position of conflict here, but I do have a lot of knowledge about how things worked when they worked well in Lillooet in the past. The main differences that I can see between the current doctors that we have, our problem is with the practice ready assessment doctors that we're currently employing in Lillooet. Previously, we had doctors who worked well as a team and helped each other. That is no longer the case. They worked with staff and the auxiliary health services in the community and the larger community and cared about the community. And that's not the situation that we have now. Recently, with some of the closures, we had doctors working in the clinic while our emergency room was closed. It is a little less stressful and certainly more profitable to work in the clinic, but for our community, not to have an emergency department, like I know you all know, and I'm upset speaking about this because you feel quite helpless. The anxiety for the community, I mean, the young families and some of our older folks and so forth. The suggestion that we get at the last minute from Interior Health to present at Royal Inland is not that helpful. Like I've spent, unfortunately, for various reasons, quite a bit of time at Royal Inland in the last couple of years. Absolutely excellent care all the way around. But the staff here in Kamloops, I mean, they're maxed. They are working at over capacity already, and they do not need the long lineup of patients from Lillooet and everywhere else to be sitting in the hallway waiting for care. We could increase the skill set of our nurses. We have very good nurses. And they're willing to do more, and they work well when they have, for example, Rudy, the emergency room doc on call, giving them some guidance. Their skills are very good. But if we're going to be asking them to do more, Interior Health has to support them with training and certification and so forth. And also, we need to improve our ambulance services. I mean, they're reorganizing around these last minute closures, trying to pull extra staff in because they know the worst case scenario is quite likely to happen. We have, Director Demers online here, people that travel at least a couple of hours to get to the Lillooet Hospital. And then they have at least a couple more. And these roads, you know, that's another challenge, but it's just not safe. And it's not acceptable to not continue to protest this. Well, we just can't do it. Increasing the ambulance service is one thing we need to do. Training up our excellent RNs and helping them with some support. Working with Rudy, for example. Another thing that sort of come to our attention and that this letter is also addressing is every single safety plan. BC Hydro is an extremely big player in the community of Lillooet. They have massive projects in the Bridge and Seton watershed, and they're going to be doing some very big upgrades to some of the dams and the infrastructure there. They're talking, you know, hundreds of extra workers in the community over the next few years, 10 years. Every single safety plan references Lillooet District Hospital, and they are alert and attending to the fact that those safety plans are out the window. And similarly, in forestry, which is still somewhat of an industry in Lillooet, is referencing Lillooet District Hospital as their safety plan. And, you know, maybe we should start thinking about that as a lever. And of course, CEO and so forth, the mayor is fully on board with. The good news is, at least, you know, within the community, Lillooet and the surrounding areas, Sal and I are SLRD, but we're the sort of bulk of the population that goes to Lillooet. And all the chiefs are completely in line with this and working together. And we'd like to work with all of you, at least in the Thompson region, to protest what is happening. I don't know what levers to, of course, I have a zillion suggestions for how we could do better, but frankly, we're not getting any attention at all. And we feel quite disregarded by Interior Health. And, you know, when we have a doctor sitting at the table and we're saying, how's the recruiting going? And they say, well, it's hard. This doctor, you know, we don't have a mosque in Lillooet. We don't have the right food in Lillooet. We don't have schools that are adequate for their kids. This is a person who's tasked with recruiting other doctors to our area. You know, and I don't want to sound like I'm discriminating, but what I can say without a shadow of a doubt is that these practice ready assessment guys are not a good fit in general for our community. I'm sure it's not great for them. It's not great for us too. And, you know, our First Nations, the most vulnerable part of our population, are being left even farther behind without services. This is a very vulnerable population. I feel that we should be doing so much better, and the complete lack of leadership. We have supposedly a health planning table with all the participation of the First Nations and all the players of Lillooet. We're all there. We're all signing up on Zoom. That's just become a moribund, completely ineffective. We haven't even met for months and months, and it wasn't very meaningful before. What we kept getting was complaints about the lack of appropriate emergency services in our hospital. And it's just, we are not seeing leadership and solutions from Interior Health that we need for our part of the province. And I know that a lot of the other people at the table here today are in the same position. So Chair O'Reilly was good enough to give me the opportunity to present this letter and speak about it. And I guess I should ask if there's any questions about the letter or any bright ideas.
Thank you for that, Director Birch Jones. And I do have I'll speak first and then I have a couple of speakers on the list, but I don't, as much as it's unique to your area, it's not unique to many small towns throughout Interior Health or the TRHD, but also the Caribou-Chilcotin RHD. And they are having significant problems there, whether you call it TRHD, Caribou, Chilcotin, IH West, Lillooet, it doesn't matter. They're closures and these are problems. I believe there's an initiative that'll be coming out of the Caribou-Chilcotin Regional Hospital District meeting, which is tomorrow. And so I will be following up with Chair Richmond. And we have been in conversations over the last weeks and months. And at our next hospital board meeting, there may be more to discuss depending on how that meeting goes tomorrow there. But I think it needs to show a united front, that it isn't one town, isn't one small closure. There's a pattern here, and it's making it very difficult for our communities, not just to thrive, but survive. So, but thank you very much for bringing this forward and allowing this conversation to happen.
Thank you.
Thank you. I have Director Thorpe and Director McNary. Director Thorpe.
I'd like to piggyback a bit on what Director Vivian Birch Jones was saying. I know that this is not a unique situation. It's happening everywhere. But what I would like to speak to is a bit of the uniqueness of the Lillooet Hospital. They tell us that we need to go to Kamloops. Kamloops is 2 hours from Lillooet, a good 2 hours. But a lot of places that are serviced by Lillooet are 2 hours from Lillooet. So we're looking at 4 hours. What I would like to ask is, when these ER closures are happening in remote locations like Lillooet, has Interior Health coordinated with BC Ambulance to ensure that is an air ambulance service available exclusively for the areas serviced by these remote locations, these remote ERs? It seems 4 hours away is far too long to try and take somebody by ambulance, assuming the ambulance is right there. So how are we addressing these emergencies in a remote location? Are we working with air ambulances?
So Director Thorpe, this isn't so much a question answer to Interior Health. This is to respond back to the letter that was presented via correspondence and through Director Birch Jones. And I think those are valid points, and I think everybody has heard your thoughts around here. Again, there may be an area where we can ask Interior Health to give us an update on how they deal with these things at a future meeting. But I think to put anybody on the spot like that in such short order, they're not going to have the answers that we're going to need. And frankly, I think we want a more wholesome picture, not just one specific area, but
No,
but
I'm
the
not
area.
thinking of one
Okay.
specific. I'm thinking of the remoteness. Maybe if they could bring it back to us at a future meeting.
Certainly we can ask for that. Thank you, Director Thorpe. Director McNary.
And just backing up Vivian Jones a little bit, on the program about and that 4 hour drive and whatnot over the roads and whatnot, if they're open at the same time. And the recruiting part, is there a problem with the recruiting part? Like, why is everybody having a problem with recruiting? I don't understand that. Do we have enough pull to try to change that through this thing, or like, get some different ideas on a recruiting program? Like, it's a problem. Everybody's having that same closure problem. Like, there's got to be a problem somewhere down the line other than just people.
Yeah, thank you for those comments. And I think a lot of the times when we sit around this board table, we're in a difficult position, as our main role, and really our only role, is capital projects. We provide capital, but obviously we live, eat, and breathe and feel our communities every single day. and you can check your emails, your text threads. We all get them, and a lot of it comes back to healthcare. So this is our area, our time to speak with IH. But again, going back to Director Thorpe, if something like that, we want a report back, we could ask Interior Health if they could talk about their human resources plan and how they're able to bring in new talent and also retain. And certainly that's something we could ask Interior Health to prevent, or sorry, not to prevent, to present at a future meeting. And again, I think it's fair to Interior Health, and I think it's fair to us to really actually get the answers we want, rather than, oh, you know, we can get you an email, you know, we'll get you an email, we'll get an email. You know, we give them a little bit heads up as much as they can give us a heads up on things. And I think that'll help us actually get the information we want. So certainly we'll take that under advisement, and we can speak with Interior Health about at a future meeting date for them to come and make a presentation on their HR strategy.
Thank you.
Thank you very much. Appreciate that. Director Grenier.
Thank you, Chair. And I appreciate we're talking about the capital side of things. And I just want to see if we can tie this in, a question to Interior Health about training in rural areas. Minister Dix reported to the City of Williams Lake on August 1st that as of July 13th, there is a 70% vacancy in the emergency department for registered nurses. So they're running with a 30% workforce in their ER. At the same time, when I asked the question about why is it so hard to get nurses to stay or to locate an ER, I'm hearing that there's some sort of an issue about training and class size in the rural areas. And so that people can't you've said earlier today that if you can train people in the area where they live, they might stay there, and that's a benefit. I'm wondering if you could come back and report to us what training facilities, what are the capacities in some of these areas where we've seen these massive shortages. I mean, at what point? 80%, 70%, 60%, 50%, 40%, 30%? I mean, come on, somewhere along the way, we have to sit there and say, why aren't these nurses being trained in areas like Williams Lake and Lillooet and 100 Mile House? What is it that we need to do in order to have a sufficient class size to keep these people in those rural areas? I realize that it's not an answer today, but I sure would appreciate tying the training with the facilities.
Yeah, absolutely. And thank you for that, Director Grenier. And I think that ties into what an HR strategy may look like. And I'm seeing some nodding from the back there. And I believe Interior Health, they have done HR strategy presentations to this board about every year and a half. And again, it might be that time when we have our next board meeting, which is scheduled for December, for them to come back if they're able to do it in that time. And I believe we're also going to have an initiative from Director Blackwell coming up under member reports directly after we discuss Director Birch Jones' initiative. We have Director Sow and Director Mayor on DeMayor, not the Mayor online, DeMayor online after to close. Thank you, Director Sow.
Thank you, Chair. And perhaps this is a question for our chair. You know, I'm just thinking about these major provincial-wide problems, and you know, similar to wildfire, and we had a task force created. I wonder if we could suggest to the province to create a task force, because it seems like or if there has been a task force addressing recruitment in healthcare before, because it seems like, yeah, we're having plans after plans after plans, and we're not doing anything new. Maybe perhaps creation of suggesting to the province to create a task force. Thank you.
Thank you very much, and your points are valid and well taken, and that's something to consider. And I would suggest when a future government is formed, and that's a discussion that can happen further on. But thank you for that point, Director DeMayor online, and then Director Bethel to close. Director DeMayor.
Thank you, Chair. Yes, as Vivian stated and others have stated, we're 4 to 4.5 hours from the Kamloops Hospital. That's if the road is in good condition and if it's even open. It closes many times. That's Road 40 from the Goldbridge area to Lillooet. And we do have a huge project coming up. BC Hydro will be putting in a 250-man camp to upgrade the Lajoie Dam for seismic. And that'll be a 5-year project. So there's going to be a lot of workers in the valley. And in the summertime, our population totally explodes with seasonal property owners and all their guests. We have a full-time population less than the 305 in the valley, but it's almost 10 to 1 recreational properties full-time. So you can imagine what we have in the summer. And again, it's that road that really causes issues. And I think when this happens, as mentioned, air ambulance and the ambulance service has to be up to snuff. When this happens, we've had incidents there where we had no ambulance service in our area, and it's a 2.5 hour drive for an ambulance to come out, just to come out, and then the wait time, where people in the valley are actually taking care of the people that are injured. So it's definitely a concern in rural areas. I did the Chilcotin a lot, and I can imagine they're in a very similar spot that we're in also. So I like that idea of seeing what they're going to come up with and having combined questions to the Interior Health. So thank you.
Thank you for those comments. Director Bevel to close.
Thanks. This is for you, Chair O'Reilly. A request that in future meetings, when Interior Health comes to present, that we ask them for a report. So we all know about the, they call them temporary service interruptions, the emergency room closures, but whether they could provide an ongoing report by facility, the number of closures, and I would say not just within our district, but within Interior Health overall. I think it's important to have a document that we can look at that says there's this many closures in this facility, this many closures in that facility, have it in front of us and have them report to it, because how are we going to measure success unless we have something to measure it against? So that would be a request if you want to consider it.
Yeah, certainly take that under advisement. And really that's something I'll have to talk with Interior Health about. And really for us to gauge and tell what success is versus what isn't. I think it's very difficult, the healthcare, the whole healthcare system and the complexity behind it. But certainly I'll have those conversations with Interior Health as I do meet with them about every 2 months to talk about what future meetings may look like and ongoing concerns from the board. But certainly I'll bring that up in our next meeting. Thank you for that comment. Thank you. No further comments on Director Birch Jones' letter, but thank you for bringing that to the board. Appreciate it. And it really got some good conversation dialogue going. Director Blackwell, you have an initiative.
Yes, thank you, Chair. I'm going to make a motion that this board requests Thompson Rivers University to come to a future board meeting and explain how healthcare education is delivered in IHA West. And part of this is because I'm starting to hear things like, the school district 73 is now offering healthcare courses within the high school, but not in partnership really with with TRU. When TRU was given its papers to become a university, part of that that agreement with the province or with the regulating bodies was to supply education to rural communities. And I can tell you in Clearwater, they've completely dropped off the map with the exception of things like welding and carpentry. Back to the growing your own, I mean, we have a nurse and several care aides that have gone and off to do healthcare education elsewhere and come back to work in Clearwater, so it works. But, we have a hospital. I know that hospital invites in, much like the question that was asked earlier, students to come see what hospital life is like, to have that experience. But why the heck, if we can equip a room, or TRU can equip a room with the 20 computers and lab space for carpentry or welding, why the heck can't that one be also used for care aid training and first 6 months or first year nursing education or related courses that they need to fill out in order to get through that. Because there's a lot of kids out there that are wondering what they're going to do with their lives in our small towns. Moving to the median house price, I think, is about $500,000 difference, as would be the rent between Clearwater and Kamloops. So there's lots of good reasons why they're going to want to stay home right out of high school and get an education from there. Thank you. Seconded
Second by
by
Director Grenier. Any discussion? No. Thank you. That being said, all in favor? Thank you. We'll prepare a letter. I'm not sure when we will get them here, but at some point in a future meeting, we will ask TRU to come present for what they do in the Thompson Regional Hospital District. Thank you for that. Anything else under new business? Seeing nothing further, this meeting is adjourned. Thank you.